All right, I think we should get started. I know there's some people that are still planning to log in. We have almost 200 registrants signed up for today from all over the world. Hello, everyone. My name is Emma Greenwood, and I'm the founder of Wooshers.com and the Pulsatile Tinnitus Foundation. This is our third international webinar. I want to thank each and every one of you that signed up to attend today. I also want to thank personally each of our wonderful panelists, 6 of them, all doctors in the field familiar with pulsatile tinnitus, and I really appreciate all the work that they've put into today's event and for their time today. I won't be introducing them individually in the interest of time, but each of them have prepared a short presentation for the first hour of this webinar. Which I hope will be really fascinating. I'm sure it will be. And we're devoting the second half to questions that have been submitted in the last month from our community to the doctors. So the second half of the webinar will be a discussion and a Q&A session based on the questions that have been submitted. In brief, I wanted to give you a little background about the foundation for those of you who may not be familiar. I started Wooshers.com back in 2009 as a patient with pulsatile tinnitus at a time and place where and when it seemed like no one else on the planet had the symptom I was experiencing. I found very few resources online. I know many of you have had similar experiences with difficulty finding specialists that understood the symptom. So I started a website and people found it. Other patients found it, doctors found it, members of the press found it, and it's just been a wonderful experience over the years to see it grow, see the community grow, and we've helped many, many people, and for that I'm really grateful. In 2016, we started discussion about developing a foundation, a formal 501c3 nonprofit foundation to assist our community. And in 2019, that became a reality. We have a foundation devoted to our community. 3 of our panelists are actually members of our board, which I am always ever grateful for. And we have a lot of very exciting things going on. We have a new website being developed for the foundation. We have a rehaul of the Wooshers.com website, which has so much information way down deep. You can't find information easily on it. We have other webinars like this, hopefully coming up soon, and a number of other initiatives. So I would like to encourage each of you, if you haven't yet made a donation to the foundation, there are links all over the Wooshers.com website to do so. Each and every penny goes right to our community, right to all of our efforts for you. So we gratefully appreciate any donation that you can make. This webinar is free today. Again, we're really happy to have all of our panelists. And we're just going to dive right into our panel presentations. So with that, we will get started with Dr. Sismanis.
Thank you very much, Emma. I appreciate very much what you have done all these years and for the help you have provided to patients with pulsatile tinnitus. I'm Aristides Sismanis. Let me just bring up my slides. From the Commonwealth University Medical Center. And I will go over my personal experience and what I have learned for the past 41 years in evaluating and treating patients with pulsatile tinnitus. It was a serendipity that I came across my very first patient, who was a young female patient with left pulsatile tinnitus. Actually, she was in the service of a neurologist, a very astute and bright young neurologist, who asked me as a consultant to see this patient who, besides the pulsatile tinnitus, had frontal headaches and blurred vision for 2 months. Now, the patient was obese. The neurologist already had listened with a stethoscope to the patient's ear, and he had detected an objective tinnitus, which was synchronous at the same rate with the heartbeat. And she also had papilloedema. So I went there at that time. If we can see here, the state of the art at the time was that all of these patients, actually, they used to call it a venous hum. All they needed was an ear examination followed by a CT. Mind you, in 81, there was no, at least at our institution, an MRI, and then proceed with an angiogram, because the main thing that you wanted to rule out was a vascular type of lesion, intracranial lesion, like an arteriovenous fistula. And at the time, they were recommending internal jugular vein ligation. And I can tell you right now, please, this is never to be considered or be done. But it used to be done. And I have seen a number of complications following this. So anyway, so I went ahead, I got a CT and an MRI and a CT and an angiogram. As I said, there was no MRI at the time, and everything was normal. So I went back to see the patient and give her the good news that she did not have a serious lesion in her head. And she told me, you know, Doc, the tinnitus, the noise, the pulsatile tinnitus went away after the doctor put that needle in my back and did what she had was a lumbar puncture with some removal of cerebrospinal fluid. So it was the first time that I realized that there was some relationship between CSF, cerebrospinal fluid, the fluid that bathes our brain, and pulsatile tinnitus. I read in the patient's chart, this was a syndrome called pseudotumor cerebri. I had no idea about the syndrome. Today is called Idiopathic Intracranial Hypertension Syndrome, IIH syndrome. And I got very interested in this patient. So I started looking prospectively for patients with similar symptoms. And this slide shows at the time, in 81, there were only 14 papers for pulsatile tinnitus. In the next 20 years, there were published 169. And then in the next 20 years, 880 papers. Why is this happening? Many of us believe that this is happening because at the same time, we're seeing a parallel increase of obesity. And if you do a Google search on the topic, you will see 763,000 citations regarding this topic. So pulsatile tinnitus is kind of not very uncommon symptom. A symptom again, which means that there might be a number of underlying etiologies, and this is our duty to find out what these etiologies are and treat them. So the very first thing I learned is to realize if it's a true pulsatile tinnitus, which is at the same rate with the heartbeat, or a rhythmic tinnitus. Now, most of the people describe pulsatile tinnitus as a whooshing sound or a fetal echo sound, or can even be high-pitched. And it's a pure vascular event. It originates in blood vessels, either when there is a turbulent flow in a blood vessel because of increased flow volume, or when there is some narrowing of the lumen of the blood vessel. So it's a pure vascular phenomenon. Now, rhythmic tinnitus is different. It can still be objective, but it's audible not in synchrony with the heartbeat. And it's been described by patients as a popping sound, as a crackling sound, clicking sound, flapping, rumbling, etc. And at the same time, you may see some spontaneous involuntary vibrations of the palate, or even the whole musculature of the pharynx. We are seeing the back of the soft palate, the uvula, but unfortunately, I don't have the video here for some reason to see the contractions, the spasms of the uvula, as well as the muscular structures of the pharynx. So the next thing I learned is to find out which is the vessel of origin. Is it a vein or an artery? And there is a very simple test for that. All you need to do is apply digital pressure, light pressure over the neck. If it goes away, it's a vein causing the problem. If it doesn't, it's an artery. And that's very important because the workup is based upon this differentiation. If it's a vein that cause, I can tell you, there's no way to have something serious like an AVF. And most of, at least 60% of the etiologies that we see are coming from a vein. And then is it audible or is not audible? Oftentimes you are able to listen to it, and this can be performed with a stethoscope. Now, in the venous etiologies, the etiologies coming from one of the veins here of the head, in our experience, intracranial, idiopathic intracranial hypertension syndrome is the #1. And then other etiologies, any type of intracranial hypertension can give you pulsatile tinnitus. And then is the dehiscence of the sigmoid sinus, diverticuli of the sigmoid sinus, and jugular bulb abnormalities. So these are the most common causes in our experience. And when they used to call it idiopathic hum, most of these individuals had nothing else but IIH syndrome or dehiscence or diverticulum of the sigmoid sinus. And here you see a map of the US showing which states, mainly in the south part of the country, the obesity issue has doubled. And these are the areas that at the same time we see spontaneous leaks of cerebrospinal fluid from the nose or even the ear have seen. So obesity has to do with pulsatile tinnitus, especially with the IIH syndrome. In 1987, I published my thesis on benign intracranial hypertension. It's the same syndrome with IIH syndrome. And pulsatile tinnitus, which can be the manifestation of this disorder. It can be the only symptom. It's a major symptom of this syndrome. Arterial etiologies, glomus tumors, intracranial vascular abnormalities, anemia, thyrotoxicosis, and then less common etiologies like migraine, superior canal dehiscence, high frequency hearing loss, and then somatosensory pulsatile tinnitus. So the radiological evaluation is done either with CT or MR, and angiograms are performed in very selected cases. Never, in my opinion, for patients with venous type of pulsatile tinnitus. So in conclusion, the history and physical examination are of utmost importance. Radiologic evaluation should be individualized according to the symptomatology and the findings. Carotid angiogram is indicated for very selected cases only. IIH syndrome, dural sinus stenosis, sigmoid sinus dehiscences, diverticuli, and glomus tumors are the most common etiologies. Pulsatile tinnitus in obese females should alert the otolaryngologist and the physician in general for associated benign intracranial hypertension syndrome. In such patients, evaluation for associated comorbidities is mandatory. We have to see the patient as a whole. Most of these patients, they have sleep apnea, they have hypertension, they're pre-diabetic or diabetic, name it. They have many comorbidities. So it's our duty to take care of them or make the proper referral. For patients who have failed dietetic measures and acetazolamide, weight reduction surgery may be considered. And then there is the sinus stenting that I bet we will hear a lot from our interventional radiologist and the colleagues that will follow my presentation. Thank you very much for your attention.
Thank you, Dr. Sismanis. That was quite a challenge, 7 minutes for a complete overview of pulsatile tinnitus. So you completed that quite well. I would like to pass the wand now to Dr. Shapiro, who will be going over the clinical overview and general approach in our cases. Dr. Shapiro.
Thank you, Emma. Thank you so much. And thank you everybody for joining today. It's really just tremendous work that Emma has done. Probably there's no single place in modern world online, as it happens to be, where there is support and information and hope for what is really thousands and thousands of people with this condition. I think I'm going to go quick. A lot of this we've heard before, and we'll hear from others. As you know, again, there's one of the messages we're going to hear again and again is that there are different approaches to pulsatile tinnitus. Pulsatile tinnitus has a definition. It's a perception of sound that is in sync with one's heartbeat, but it has many different causes. As Dr. Sismanis pointed out, probably the most important cause, and probably the most common cause too, to have emerged in the past at least decade and going back even more to his work originally, is that this whole business of venous pulsatile tinnitus, venous sinus stenosis, the association with intracranial hypertension, which often is associated, sometimes is not, and it's a spectrum. So a lot of this work is ongoing, and that's, I think, has been the biggest development in our world in the past decade or decade and a half. There are many other causes, and it is a symptom, so it's not a disease. So the difference being that might be a specific disease, like for example, intracranial hypertension might be a specific disease. Now, a symptom like pulsatile tinnitus, which is what a person might hear or somebody else might hear when they listen around the ear, can have many causes. Those causes, as Dr. Sismanis mentioned, usually are related to turbulence of flow. The ear is fine. Oftentimes, it's just hearing the blood flow, hearing sound from the inside. And so there's an irrational way of approaching it. There's a way to consider how that could be. You look at arterial causes, venous causes, and so forth. But a lot of these causes can be evaluated from different specialties. So somebody like an ear, nose, and throat specialist, or a vascular specialist, an interventional neuroradiologist like myself, would have a different training and a different approach to this. And it's important when, we'll speak about it, that when this is evaluated, a different specialist be sought until the cause is found and consider the various possibilities. Now, in terms of, so just to go back to this, obviously it's different from the constant non-pulsatile tinnitus. And it's very important for patients to try to accurately describe it. If you hear a sound in your ear, just say I have a sound, or however you want to say about it. But it's important for the doctor to hear that this is really not ringing in the ears. It's very, very important because of how we are trained and how kind of the thought patterns of medical evaluations go. If you say I have a bruit, which is this medical term for like this, a pulsating kind of sound, or something along these lines, it sets the doctor or whoever you're seeing on a different path. They might not be looking at the ear so much, they might be thinking of blood flow. Now, okay, we heard about this already. Basically, I kind of mentioned that before. The sound can be on one of both sides. That does affect kind of the probability of finding what the cause is, I think, and also how we approach it. And there is a rational workup. And I think the rational workup from a medical perspective really depends on understanding of medicine, of anatomy. If we're talking about vessels, then as you probably know, there are arteries and veins in our bodies. And so some of the sounds are made by arterial-based flow. Other sounds are made more on venous side, as Dr. Sismanis said. It's probably much more common to be venous, actually. Some are made by these arteriovenous connections, which could be like a fistula, or one might say that a glomus tumor is also like an arteriovenous shunt of it, in a way. And so that's how we approach it. The evaluation is not standardized across practitioners, as I mentioned. It really is not something that most people are taught in medical school. That's just the reality of it. And I think Wishers has done a tremendous job in educating the physicians as well as the patients. And often it's the sufferer that educates the doctor about what really is going on and where to look. And there's a lot of barriers there, definitely. But I think that, the evaluation is focused on evaluating the nature of the sound and directed to blood flow. As Dr. Sismanis mentioned, really in this world of where you see, people see doctors on Zoom or whatever, virtual visits. I do that too. We all do that. That's reality of everything modern. But physical examination is really very important in this. At least that somebody at some point who knows what they're doing should be putting a stethoscope to the ear and trying to listen and seeing if they can appreciate the sound. I think one of the main issues is like, how do you find a specialist? Like, who should you see? We'll talk about that. There is really no going around seeing a specialist, not just for this, but for any rare or not so rare disease. Like, oftentimes you need a specialist to see that. How to do that is easier said than done. But I think sometimes the causes are easier to find, sometimes they're not. We talk about sharing images. Emma talks about that a lot. Whenever you get imaging studies, whatever they are, tell them to burn a CD or do whatever to make sure that you can. So a lot of places can allow you to kind of see things online now, that you can show it to others and you'll be able to have a record of your images, not the report. The reports are not always right, but the images, there are ways of, people see things differently when they look at the same thing. Circulate the studies. There are some, you see some links down there from the Wishers. Our website, Neuroangio, has information on pulsatile tinnitus. So there's a lot of good information out there on pulsatile tinnitus. I think with that, I will really conclude. Just to go back to, I just want to emphasize, as Dr. Sismanis mentioned, angiography has become, like, as a diagnostic tool, is receding. So we do venous angiography to measure pressures in the veins to see if there's a gradient across the stenosis or whatever. That's a different story. But a standalone angiogram, often not necessary. We prefer MRA, but we'll get into that a little bit more. MR-based imaging, because it's getting better and better. But we'll get into that a little bit later. With that, thank you for your attention.
Thank you, Dr. Shapiro. And I did also want to plug NYU Langone, your institution, which has been a partner of Wishers since the beginning. We used to have support groups when we were 8 or 9 people at a cupcake shop in New York City, and doctors from NYU Langone attended, and it's just grown and grown since then. So I just wanted to also thank your institution for all your support for our community. And next we will go to Dr. Abdelkader, who will discuss imagery and tests for pulsatile tinnitus patients.
Thank you, Emma, for this invitation and for all your hard work in this. It's much appreciated. So I will review basically the imaging investigations of patients suffering or complaining of pulsatile tinnitus. So the very common 4 questions that I'm commonly asked when I see patients with pulsatile tinnitus is, first, should I get imaging or not? So we should answer this question: who should get imaging? The second question is, which imaging study should be obtained? And what are the advantage and disadvantage of each modality or each radiological study? And then what if my radiological investigation or study is normal? So before we go into answer those questions, we have to know the different causes of pulsatile tinnitus. And there are, as described before, and as very well known, that causes of pulsatile tinnitus can be divided between vascular and non-vascular causes. So this is extremely important that not only vascular causes can give pulsatile tinnitus, there are also some non-vascular causes. And as you can see here, the ear is lodged between the bone, next to a vessel, next to an artery, next to the vein. There are muscles, there are, the bone coverage between those vessels and the ear. There are some also muscles inside the ear. So all those structures, if there are any abnormality, may cause pulsatile tinnitus. Now, obviously, the most common cause of pulsatile tinnitus are vascular causes that can be divided between arterial causes, venous causes, or problem between the connection between the artery and the veins. We call that arteriovenous causes. Now, I'm not going to discuss in details the different causes of pulsatile tinnitus, but it's very important to know that most of the causes of pulsatile tinnitus are venous in nature, so that's usually benign and treatable, most of them. But there are also some serious causes of pulsatile tinnitus. Fortunately, they are very, very rare, and that includes some arteriovenous problem, some tumors among the non-vascular causes, that some bone problem, anemia, hyperthyroidism, pregnancy. But again, the most common cause of pulsatile tinnitus is venous, and much less likely the arterial causes or the arteriovenous causes or the tumor. So those are very important to know, because when a physician or a doctor order an exam, should take in consideration the different causes of pulsatile tinnitus. So there are, and this is, as I said, the venous causes are the most common, and we can divide them. There are many classifications, but this is one of the classifications, and you see how many problem in the venous structure can cause pulsatile tinnitus. So I'm not going to detail the different causes, but I'm showing this to show that there is an underlying cause in more than 70% of cases in pulsatile tinnitus. So if a patient with pulsatile tinnitus, there's a chance that we may find the cause of this, the cause of the whooshing sound in around 70 or more than 70% of the cases. So that's why every patient with pulsatile tinnitus should undergo imaging. And this is extremely important, not only to look for serious causes like tumor or arterial causes that are already very rare, but to look for treatable causes of pulsatile tinnitus. So which imaging study should be obtained? So I'm going to review very rapidly the different modalities that we have and that we can, but it's extremely important to know that there is no single modality that will help or detect all causes of pulsatile tinnitus. Most of the times we have to order more than one study. Most of the we'll review later that MRI probably is the most or the best single study that will show us most of the causes, but most of the time there are complementary studies. Most of the time we'll have to order MRI and CT scan, ultrasound and CT scan. So ultrasound, the advantage of ultrasound, as you know, it's ultrasound that it's non-invasive, it's a very safe exam, it does not have any radiation, it does usually not need any contrast, and main advantage of ultrasound, it will show the blood flow in the neck. So carotid stenosis or carotid disease in the neck is one of the common cause of pulsatile tinnitus in elderly patients. Usually they have buildup of blood causing stenosis, and then disturbance of the flow will be transmitted to the skull base and to the ear. So this is the main advantage of the ultrasound. Now a CAT scan is also non-invasive imaging investigation that usually it's fast. One of the disadvantages of the CAT scan that it will involve some radiation, so it's X-ray imaging technique. Honestly, the radiation is extremely minimal with the new techniques that we have currently. Obviously, we're not going to order CAT scan for a pregnant woman, or we try to avoid it if we can. The advantage of the CAT scan that it will show us the bone structure surrounding the ears very, very well. Also, when we inject contrast, we'll see the vessels. One of the limitation or disadvantage of the CAT scan that it will not show us the nerves or the soft tissues next to the ear. So the soft tissues and the nerves, those are much better seen on the MRI. So the MRI is also non-invasive. That means that except of the dye that the doctor will need to see the vessels, so it's usually non-invasive. It will take a little bit longer time, and as you can see, the MRI usually is like a small tunnel, and it's usually some of the patients, they are call that claustrophobic, so they're afraid of the narrow spaces. It will also, we usually require contrast. The dye we inject to see better the structures. Again, the MRI does not have any radiation. It's completely different technology than the CAT scan. And the advantage is to see the inner ear, the nerves, and the soft tissue. One of the disadvantages of the MRI is, unfortunately, we don't see the bone as well as the CAT scan. So except of the bone, MRI is better than the CAT scan, but the only advantage again of the CAT scan is we'll be able to see the bones surrounding the ear very well. Now the MRI have some advanced or some subcategories of the MRI. We call that the MRA and the MRV, and those are of the same method, the same technique, MRI, but we'll have to use different acquisition, different method to look to the blood flow either in the artery or in the vein. But as I said before, if there is single one exam that I would order, I would choose MRI because it will show almost everything. It will, especially with the new MRI, it will show even the arteries, it will show the veins, it will show all the structures, and except of the bone, it's really a great technique. And add to that it does not have any radiation. Now, angiogram is invasive. That means that the doctor will have to go through the vascular system of the body. It definitely has more radiation than the CAT scan. We will need to contrast or dye to see the vessels. The only advantage of not the only advantage, but one of the main advantage of the angiogram, it will show us in real time the circulation of the blood. As we said, most of the causes of pulsatile tinnitus is vascular in nature. And that's why one of the common indication of the angiogram nowadays is just to rule out or to confirm the presence of fistula, and obviously we'll use angiogram if we are planning to do any treatment or vascular treatment of the cause. But as my colleagues mentioned before, it's because it's invasive, we try to avoid it, especially with the advancement of other techniques, the MRI and the CAT scan. We can almost 95% see all without the need of the angiogram. So angiogram is very limited indication, usually in the terms of the fistula, which is connection or shunting between the artery and the vein. That's why we need a real-time imaging to see how the blood is coming from the arterial side to the venous side to see this connection. Now, usually if a patient presenting to me and having pulsatile tinnitus, usually especially when the exam, as Dr. Shapiro mentioned, the exam is extremely important. So if a patient after the examination, we would have to differentiate between the different causes of pulsatile tinnitus. Is it subjective or objective? If the patient hearing the noise or the doctor as well hearing the noise. So if it's subjective, we can divide them as we said, the most common causes are vascular. So we ask the patient if we compress on the neck of the patient and the noise disappears. So we say that it's attenuates or decrease with the jugular or neck compression. So that's most likely venous in nature. If it does not, so probably it's arterial. Now, if the patient is elderly or old in age, we probably start with ultrasound to look for the carotid. If the noise is venous in nature, that means it change the quality of the noise change with the compression of the neck, and the patient is middle-aged, overweight, or obese, we are suspecting IIH, that there's some mistake here. So intracranial hypertension, we would go with MRI with contrast. Now, if those studies are negative and the patient is still complaining, we can go for CTA. As we see here, that it depends on the patient, it depends on the age of the patient, it depends on the symptoms of the patient, it depends if the noise is just heard by the patient or the patient and the clinician. So there is some algorithm or some different options that we have. Now, if there is a suspicion of intracranial fistula, if the noise is objective, that means you can hear it from outside, the different person can hear it from outside, we may directly go for MRI to rule out fistula, or ultimately we may need catheter angiogram. So this is kind of an algorithm that we follow in terms of what kind of modality or investigations to undergo for patient with pulsatile tinnitus. So in summary, every patient with pulsatile tinnitus should get imaging, first to rule out serious causes, which are very rare, but most importantly to look for treatable disease. Second, point is there is no single best radiological exam to detect all causes of pulsatile tinnitus. MRI probably is the better, especially if it's middle-aged women with venous pulsatile tinnitus. That means that the change in the head position and the valsalva with the compression of the neck, that's probably venous in nature. And with the MRI with contrast, especially the new MRI with contrast with very thin section, that means the very high resolution images, we can see the vessels, we can see all the other structures. And unfortunately, even even with all the advancement of technology, a lot of initial investigation are usually reported as normal. But if the patient is convinced that there's something going on, is suffering from the symptoms, a second opinion with an expert in PD is definitely needed. Because, as I said, in more than 2/3 of the cases, we may be able to find a post-pulsatile tinnitus. Thank you.
Thank you, Dr. Abdelkader. Each of these presentations has so much information. I understand we're fitting in as much as we can, and it's a lot to cover, but I appreciate these very thorough presentations. Next, we will have Dr. Higgins, who I'm especially happy is joining us today from the UK. We have a rather huge UK component to our community. I know many of you are very excited to see Dr. Higgins. So Dr. Higgins, thank you very much to speak on most common causes.
Brilliant. I'm just trying to share my screen here. Okay, thanks very much, Emma. So commonest causes of pulsatile tinnitus. I mean, we've gone through them a bit. There are a huge number of causes, of course. But I think what people are really interested in is, I mean, most of these causes are actually relatively easy to diagnose if you get the imaging. But what most people are interested in really is what's going on with their pulsatile tinnitus if nobody knows what's going on. And you can shorten this list quite quickly with imaging. Arterial stenoses, they're not too difficult to diagnose with the various non-invasive imaging. Head and neck tumours, not too difficult to diagnose anymore. Hyperdynamic circulation, so thyroid anemia, that's not too difficult. So you can quite quickly shorten the list. And I've left dural arteriovenous fistulae up there because I think you can diagnose those with non-invasive imaging, but until you've had a catheter angiogram, you can't really be sure that you've excluded a dural arteriovenous fistula. So that leaves us really what's going on when the doctor has done. It usually leaves you with benign intracranial hypertension or venous disorders, and all these things are mixed up together with each other, really. If we look at idiopathic intracranial hypertension, the problem is that why is it so difficult to diagnose idiopathic intracranial hypertension in someone who presents with pulsatile tinnitus of unknown cause, when it's well known that pulsatile tinnitus is a symptom of idiopathic intracranial hypertension? And to think about this, you have to go to how the clinical features and the definition of IIH. So the clinical is usually the patients are young, overweight, and female. They don't have to be, of course. And there's usually headache, and then there's visual disturbance with swelling of the optic nerve heads, and that's called papilloedema. And that's the papilloedema is the thing that is feared by doctors and patients, because that's what leads to the blindness. But then it's defined by having an intracranial pressure greater than 25 centimeters of water, and there has to be no known cause. And you diagnose it by lumbar puncture. Now, if you look at the clinical features of idiopathic intracranial hypertension, we've got the characteristic phenotype, young, overweight female, but again, doesn't have to be, and the headache and the optic nerve swelling. But then there are all these other symptoms: fatigue, dizziness, anxiety, depression, impaired concentration, memory, muscle, joint pains, and of course, pulsatile tinnitus and more. Lots of symptoms. And if you thought, well, I've got pulsatile tinnitus and I've got a bit of this and may not be young or overweight, could I have idiopathic intracranial hypertension? And if you ask your doctor, that, he'll say, well, what you mean you've got idiopathic intracranial hypertension without papilloedema? Well, it's very rare, and actually we don't look for it unless we've got good reason to do so. So let's look at the definition and clinical features of idiopathic intracranial hypertension without papilloedema, IIH-WOP. So the patients have headache and they have no swelling of the optic nerve head, so they don't have any papilloedema. So in fact, they don't actually have any signs, and there's nothing for the doctor to go on except what you tell them about your pulsatile tinnitus or your headache or anything else. But again, this is another condition that's defined by having an intracranial pressure of greater than 25 centimeters of water of no known cause. So if we look at the clinical features of this condition, IIH without papilloedema, the phenotype is very similar, usually young, overweight females. They've got a headache, usually, but not always. But there's no swelling of the optic nerve head, so there's no papilloedema. As I say, there's nothing for the doctor to go on except what you tell him about your symptoms. But you might have all these other symptoms, including, of course, pulsatile tinnitus. So you ask, could I have idiopathic intracranial hypertension without papilloedema? And the answer you'll get is, well, this is a very rare form of IIH, 5%, and so we don't look for it unless we have a very good reason. But I think there's some misplaced thinking here, and it's worth just going through this for a second. Because if you look at the clinical details of a patient with IIH-WOP, the absence of papilloedema means actually that there's not really any serious fear of a patient going blind. And the clinical syndrome is actually generally milder than patients who have the full-blown syndrome, IIH. And if you look at the pressures of patients who have idiopathic intracranial hypertension with papilloedema and compare them to patients who have it without, and obviously there are many more patients with than without, because the IIH is much more frequent, you find that the mean pressure is a bit higher in patients who have the full-blown syndrome than in patients who have idiopathic intracranial hypertension without papilloedema. So you've got a condition here, IIH without papilloedema, which seems to be clinically milder than IIH, and also has pressures that are generally less than those of patients who have the full-blown syndrome. So this doesn't really make sense, because neither in medicine nor in nature is the milder form of an illness ever rarer than the most severe. It's like saying, the highest mountain is the rare. It's like saying the highest mountain is the most frequent, and the little hills are rare. Or a patient with severe rheumatoid arthritis is much more frequent than a patient who has a mild version. It doesn't really fit with medical illness. So this is probably wrong. In fact, it's much more likely that IIH without papilloedema is more frequent than IIH itself. And the reason it's not seen is because it's not looked for. And in fact, the difference in if you look at probably the epidemiology here, there's probably 100-fold, I would say, mismatch between the perceived incidence of idiopathic intracranial hypertension without papilloedema and idiopathic intracranial hypertension with papilloedema. But much more likely, this is the rarer and severe form of the disease, and this is the much more frequent and milder form of the disease. And then you have to ask yourself, what's going on in patients who don't make the cut? They're less than 25 centimeters of water. Well, if you go back to the definition of these diseases, both types, idiopathic intracranial hypertension with or without papilloedema, they're defined by having a pressure greater than 25 centimeters of water. But does that mean if your pressure is 24 centimeters or 23 centimeters of water, you don't have IIH? Now, what about if your pressure is 20 centimeters of water, you do a lumbar puncture, you take the pressure down, and your pulsatile tinnitus goes away? Does that mean you don't have a diagnosis? I don't think so. I think you've got a variant of not quite idiopathic intracranial hypertension. And probably what's going on is there's some underlying pathology, and I think this is where the venous side comes in, where possibly increasing venous obstruction is actually creating a tree of disease with IIH at the top, IH without papilloedema lower down, and patients down here who don't quite make the cut, any of whom might have pulsatile tinnitus. So my commonest causes of pulsatile tinnitus when the doctors are stumped are IIH, IIH-WAP, and not quite IIH-WAP, and actually not necessarily in that order. Thanks very much. That's me.
Thank you so much, Dr. Higgins. We actually have quite a few questions about IIH in our Q&A collection, so we'll be speaking back on that topic in just a bit. I'd like to now hand it off to Dr. Eisenman for management and treatment.
Thank you very much, Lima. I'm on a small screen today, so let me just pull up my talk, which I think you should be seeing now. Is that correct? This is going to be a very brief talk. It's going to be very brief just because the topic is so vast and broad that it's impossible to cover it. I was going to be talking about management of pulsatile tinnitus. And the most important thing that you need to know is something that a couple of our speakers have already mentioned, which is that to manage the problem, you have to know what's causing the problem. So I'm just going to cover 3 points relatively briefly. The distinction, as has already been covered, of pulsatile tinnitus as a symptom versus as a disease process. A symptom means, this is what you are what you're hearing or what you're feeling, like headache or knee pain or abdominal pain. Those are all symptoms, but there can be a myriad of underlying causes for each of them. And your treatment for abdominal pain, for example, belly pain, will depend on whether it's pancreatitis or an ulcer or some other problem. The treatment is going to depend on what it is. Now, having said that, tinnitus, non-pulsatile or central or non-rhythmic tinnitus, whatever you would want to call it, is sometimes treated just as a symptom rather than the underlying disease process that causes it. And the same, to a certain extent, can be done with pulsatile tinnitus as well. There's a treatment modality called tinnitus habituation therapy, which involves a few different stages or facets that helps people sort of habituate or adjust or adjust to the presence of that sound and to a certain extent extinguish the sound. It's less intuitive that should be valuable for people with pulsatile tinnitus, but it can sometimes be helpful for people with pulsatile tinnitus. So if you are someone who has pulsatile tinnitus and the underlying disease process cannot be identified, there still can be non-specific treatment for you, considering the tinnitus simply as a symptom rather than identifying the underlying disease process. As the other speakers have already mentioned, there are a myriad of causes. This is an incomplete list. We like to conceptually think about pulsatile tinnitus as abnormal sound production. You have something going on in the body that is producing a pulsatile or pulse synchronous sound that otherwise you should not be hearing, versus abnormal sound perception, where the blood vessels are doing everything that they're supposed to do, but the ear has a heightened sensitivity to hearing even potentially normal vascular sounds in the body. And then commonly you can see combinations of these. And then there are a number of causes that are of unknown mechanism. And IIH is something that has already been mentioned a bunch. I've kept that under unknown, even though there are many thoughts or possible understandings of why IIH causes pulsatile tinnitus. I've left it in here for whatever reason, but migraine and Meniere's disease are very important processes to be aware of that can be associated with pulsatile tinnitus for reasons that are not clear. It's also important to keep an eye on these sort of combinations. Many of these isolated causes are relatively straightforward to diagnose, but people who have complex or recalcitrant cases of pulsatile tinnitus, it's often the case that it's more than one thing that is causing it. So just to give you two examples, and these are all examples of things we have seen in our center, but you can have an abnormal blood vessel or a normal blood vessel in an abnormal location that has sort of eroded into a structure of the inner ear. So we've seen, I wrote this as a superior petrosal sinus eroding into the superior semicircular canal. That we see actually not uncommonly, but we've seen aberrant vessels, abnormal vessels, branching off of the superior petrosal sinus or other intracranial blood vessels eroding into the inner ear in locations. So that's a combination of an abnormal sound production. You have an abnormal vessel or tangle of vessels, but they've also eroded into the inner ear, which for reasons I don't want to go over will heighten the ear's sensitivity to body-generated sounds. This was a case we had just recently, sorry for the typo, a patient who had a sigmoid sinus diverticulum as part of her I'm embarrassed to say preoperative evaluation because we were thinking about doing surgery for her. We found that she had anemia. The anemia was corrected and her pulsatile tinnitus got better despite the fact that her sigmoid sinus diverticulum was still present. So it's very, very important to identify the cause if you want to treat something specifically, and not to forget that there could be combinations of causes. I'd like to dive right into a controversy, which I know will get some of my colleagues stirred up here, which is transverse sinus stenosis and sigmoid sinus wall anomalies or sigmoid sinus diverticulum or dehiscence as causes of pulsatile tinnitus. These are often thought of as independent causes of pulsatile tinnitus, but the reality is probably that they are most commonly found together. Here's a little schematic of a sigmoid sinus diverticulum protruding into the mastoid with a transverse sinus stenosis immediately proximal to it, which is where they most commonly are located. And in fact, if you look closely at some of the data on stenting transverse sinus stenosis for pulsatile tinnitus, here's a paper from one of our colleagues who was on a previous webinar, Athos Patsilidis, looking at 42 patients, I think it was, whom he stented for their transverse sinus stenosis. Every single one of them had some abnormality in their sigmoid sinus, what he was calling post-stenotic aneurysms, either saccular or fusiform aneurysms, but these were all abnormalities immediately distal, immediately beyond the transverse sinus stenosis, that is to say, in the sigmoid sinus, that were found in every single patient in whom he was doing that stenting. Those who had what he called a saccular aneurysm, which is really just another term for a sigmoid sinus diverticulum, they also coiled the diverticulum at the time of the stenting. The ones who had what he described as fusiform, it's quite likely that they had what we would call a sigmoid sinus dehiscence. You would need to do a CT scan to be able to see that. That is something that just can't be seen on an MRI. And as previous speakers have noted, if you don't do the right test, you're not going to see the underlying diagnosis. So I think the reality is that transverse sinus stenosis and sigmoid sinus diverticulum and dehiscence usually go together, which raises the question about, well, should you put a transverse sinus stent in to get rid of that, which would seem to be fundamentally addressing the more serious problem, or should you do sort of an operation outside of the blood vessel rather than a stent inside of the blood vessel to reconstruct the sinus wall? And I think the answer is that both of those would treat this. And we've seen examples of people with sigmoid sinus diverticulum who get a stent without putting a coil in the sigmoid sinus diverticulum, and their pulsatile tinnitus gets better. So it's likely that with transverse sinus stenosis and sigmoid sinus wall anomalies, it's the combination of two of them, in our opinion, that's causing the pulsatile tinnitus. And you could treat either one of them and it would get better. That raises the question of which one should you favor treating. In our center, and this is not just my opinion, this is the opinion of our interventional neuroradiologists, our neuro-ophthalmologists, our neurologists, and the neuroradiologists as well. If someone does not have headaches or papilloedema, we will favor doing an operation on the sigmoid sinus wall anomaly. If they do have headaches or papilloedema, we will much more strongly consider as transverse sinus stent. The very last thing I would just like to point out is that there is a very, very strong association between both non-pulsatile tinnitus and pulsatile tinnitus with anxiety and depression. That relationship seems to differ between the two different groups, that with non-pulsatile tinnitus, or what might be called non-rhythmic tinnitus or central tinnitus or regular tinnitus by some people, anxiety and depression probably make the tinnitus worse. Whereas with patients with pulsatile tinnitus, it's more commonly the case that they are either independent of each other, or the pulsatile tinnitus has provoked what we would call a reactive anxiety or a reactive depression. And so treating the anxiety and depression with pulsatile tinnitus won't, in most cases, improve the pulsatile tinnitus like it might with non-rhythmic tinnitus, but it's still very, very important to be aware of the existence of anxiety and depression. And even if they won't help get rid of the pulsatile tinnitus, it's important to always keep in mind that those should be treated when present, when they are associated with pulsatile tinnitus. And I'm going to stop there and unshare my screen. Sorry. And thank you very much. Really, it's such an honor to be able to be a part of this group with so many of my esteemed colleagues here. Thank you, Emma.
Thank you. Thank you, Dr. Eisenman. And many of the topics that you covered will be revisited during our Q&A session, particularly the transverse sinus stenosis discussion, which I also expect will be a lively one, as well as the topic of anxiety and depression among patients in our community, which I think I agree is such a huge and very important topic. Last but not least, we have Dr. Coelho to start the discussion about questions that we as patients can ask our doctors and discuss with them. So with that, Dr. Coelho, please.
Great, thanks, Emma. First, I want to thank you and to the foundation for having me on. This is a real treat for me. I know many of the other folks on the panel have been on this already, but it's my first time, and it's nice to be invited to the party. Also, commend the co-panelists on their lectures. It's always hardest to speak last because a lot of the subjects already been covered, sometimes better than you ever could, which is good. I also want to thank you, especially Emma, for giving me this particular subject, because I really had to take my doctor hat off, and that's hard for us as doctors to remove a hat that we've had on for 20, 30, 40 years, and to think about things from the patient perspective, and to think about, well, what would I do if I was the patient and I didn't live, next door to Dr. Sismanis or Dr. Eisenman or Dr. Higgins, any of the these big people. So I'm going to kind of go through my approach and what I would recommend to a patient if they were, how to start. So let's see, here we go. So rule number one is, as I'm taking off my doctor hat, I realize that doctors, we really like to ask questions. We want to ask you, we need to draw it out of you. We have a certain checklist of things that we need to ask to figure out, is this venous, is this arterial, what are the signs that you're having, what are the symptoms, what are the history? So, there have been studies that show that doctors will interrupt a patient within about 7 seconds of them starting to talk. So although we love to ask questions, we don't really love to answer questions. So when you said that So, questions to ask your doctors. I would say that some doctors don't like to answer questions, but that is unless they're really good. So I'm going to try to help you guys figure out what are the right questions to ask. It's all about what are the right questions to ask, because if you can ask the right questions, then you can come to the right answers. And if you come to the right answers, you have the right diagnosis. If you have the right diagnosis, then you can have the right treatment. It's all about finding the right diagnosis. As others have said, again, more eloquently than I have, pulsatile tinnitus is not a diagnosis. It's like saying pain. Pain is not a diagnosis, right? It's what's causing that. What's causing that? So generally, on the heels of rule number one, which is doctors don't like to be asked questions. But if your doctor won't answer your questions, that's an easy one. Go find another doctor, because that's our job. Our job is to work with you to try and figure out what the heck is going on. And if somebody won't answer questions or can't answer their questions, it means they either don't know enough about pulsatile tinnitus, which is certainly possible, because as it's been mentioned before, generally not high on the training for most doctors. They don't care enough to help, which is not good. You want to have an empathetic partner with you to help you figure out what's going on, or sadly, sometimes both, if that's not the case. So rule 3 is when it comes to these questions, the doctors are going to ask you questions and you're going to ask the doctors questions. Always answer truthfully. And it's totally okay to say, I don't know, or it's okay to say, what does that mean? Or I don't understand what that question means, or what is this? We doctors, we get caught up in our jargon and our own little world. And it's very easy for us to talk on the doctor level, but sometimes it's hard for us to talk on the patient level. And that's a skill that doctors need to work on. So what are the things to think about before you talk to your doctor? What are the things your doctor's probably going to draw out of you? Tell a story. The history for most things is very helpful in terms of knowing, in terms of being able to diagnose. And I would argue that history, meaning when did it come on? How did it start? How severe is it? Where is it? What makes it better? What makes it worse? Any associated symptoms, anything that has been traveling with it at the same time since it's been going on, anything that's gotten better since this has gotten worse, etc. There's lots of questions like that. Those kind of questions really clue in the physician in terms of what's on the differential diagnosis. Differential diagnosis is a term that we doctors use that means, all right, I'm talking to you, but as you're talking to me, I'm not only listening to what you're saying, I'm also kind of, things are coming off of my list of things this could be, other things are going onto my list of things this could be. And then once you've made that kind of final list of 3, 4, 5, 6 things, okay, it could be one of these things. Not everything presents like a textbook classic version. It could be one of these things, and then it'll help you kind of guide where to go next. We are not big fans of the shotgun approach, which is you come in, you say, I have pulsatile tinnitus. Okay, let's just get every test on the planet, and whatever sticks against the wall sticks, and whatever doesn't, and we're just going to pick and choose which information fits our story. That's not a great way to practice medicine. It's not a great way to come up with diagnosis. It has to fit. You can't make a square peg fit into a round hole if a finding on a particular imaging modality doesn't fit with the story. So the story is really, really key. So in that regard, make sure that your story is really good. Not good in terms of like, exciting. It doesn't have to be exciting, but it has to be as detailed as possible. Better too much detail than too little. A good doctor will help steer you in the right direction. So it is not an hour and a half long thing. It's always amazes me, though it shouldn't, is when patients show up and I say, well, what have you done? Well, I saw 3 other doctors and I had 6 imaging, done. What did you have? I don't know. Did you bring it with you? No, I didn't. Didn't bring it with me. Didn't know I was supposed to bring it with me. Bring everything with you. Your doctor's there to help you. Help us help you. So if you bring everything possible, it's our job to sort it out. You shouldn't have to worry about that. That's why they pay us the big bucks, is to sort these things out. That being said, you don't have to bring an Excel spreadsheet of every single symptom you've had since 1972. that says, on Tuesday, March 13th, 1986, I sneezed and my pulsatile tinnitus got a little bit worse. And that's just one entry of 46,000. And I have seen patients who brought that in. The important part is that this is a dialogue and it goes back and forth, and a good physician will help steer that conversation for you. But it helps to be prepared. Do your research in terms of who to see. So who do you go see? Not everybody has somebody who is comfortable with pulsatile tinnitus living in their area. So you have to do your research in terms of who knows their stuff. Do not trust online reviews. We all, if I go to a restaurant and I have a nice meal, I personally don't feel compelled to write a review on that nice meal. It was a world's most amazing meal, maybe I would. If it was a world's most horrible view, maybe I wouldn't. But you get a selection bias. So those things, and people will pay to increase their online reputations. Fortunately, mine is pretty good. I've worked very hard for that, but I also try not to pay too much attention to that. And I encourage you guys not to either. A good place to go is to the physician's own website to see if they talk about it. So who is somebody who could be good at diagnosing, most importantly, diagnosing, and if not treating, then getting you to the right person who can treat pulsatile tinnitus. And that really could be lots of different answers. It could be an otolaryngologist, it could be a neurosurgeon, it could be a radiologist, it could be your primary care doctor. It's just somebody who has an interest, somebody who cares about you, somebody who is willing to do the legwork, not necessarily somebody who is a world expert in something, but somebody who knows what they're talking about and has done it. Resume or CV isn't everything. We've got some people on here who've gone to the top name institutions in the world, but some of the best physicians I know are places, people who may not have a CV that looks the same. It doesn't matter. I'll let you in a little secret. It doesn't matter where you went to medical school. It matters where you did your training. It matters who you did your training with. It matters what your clinical interest is. So training is variable, experience is variable, interest is variable, and aptitude is variable. You really need to have all four of those. How, as a patient, to parse that out and figure out who needs to be seen can be challenging. Certainly online reviews that are specific towards individual people or places can be helpful, but I find that institutions, universities, hospitals, etc., that generally advertise themselves as pulsatile tinnitus, places that treat pulsatile tinnitus are generally a good place to start. There definitely are good questions to ask. There are many, many, many good questions to ask, and you should be asking these questions. Don't be afraid to ask questions, even though I started out by saying, we don't like to be asked questions. A bit of a falsehood. I do like to be asked questions, as long as, and any physician who's comfortable in what they do should feel comfortable asking those questions. So so let's say you don't have all those things that we had before. You don't have somebody who advertises themselves as an expert in pulsatile tinnitus. How do you figure out if it is? Well, you go and you kind of trial and error it and figure it out. Have you seen patients with pulsatile tinnitus before? I think a very important question to ask that's been touched on today is my pulsatile tinnitus venous or arterial, or a combination of both, but those often present as arterial. If your doctor can't help you figure that out, if it's venous or, and there's some very, very easy ways to figure that out, either just by talking to the patient or very simple things on a physical exam. Can you hear my pulsatile tinnitus? Dr. Shapiro, I believe, talked about using a stethoscope. That's a critical portion of the examination. If somebody's not listening to your pulsatile tinnitus, then they're not doing a thorough exam. Can't tell you how many people that I've seen over the years that I put a stethoscope and they're like, "What are you doing?" It's like, "I'm listening for your pulsatile tinnitus." Like, what? Nobody's ever done that before. And then if you hear it, if you hear a bruit, you hear a whooshing, patients are oftentimes very relieved because they're like, "Oh my God, I'm not crazy. You hear it, somebody else hears it. This is so nice. It's validation that there is something going on. We just need to figure out what it is." What scans to get and when? I touched on that briefly. I've already had scan X. Do I need to get another version of scan X? Do I need to get scan Y? What's on an MRI? What's the difference between an MRI and an MRV and an MRA and a CT scan and a CT angio? What are the places of these, and do I need to get one if I haven't had the other? All that is very highly dependent upon your clinical presentation of your pulsatile tinnitus, what your history is, where the physical exam may indicate that it might be coming from, whether it's arterial, venous, etc. And again, I mentioned this already, but what is my diagnosis? Pulsatile tinnitus is not a diagnosis. Do not be satisfied to leave the doctor's office with a diagnosis of pulsatile tinnitus. Your symptom is pulsatile tinnitus. Your diagnosis is something else. Now, it's okay if the doctor says, I don't know. We're gonna work on it. Here's what we're gonna do. Here's our game plan. We're gonna go down this pathway. If we find it this way, fantastic. We'll treat it. If we don't, earlier it was mentioned that 70% of patients will have a diagnosis. That's good, right? But there's 30% of people, and I imagine many of you are on this call right now that have what fit into the 30%. We as physicians can do better. We have done better. We should do better about finding out those other 30%. It's out there. Sure, we know a heck of a lot more now in 2022 than we did in 1981 when our Sismanis started this whole up. But we certainly have more to go. When it comes to the treatment of this, do you treat this? Well, actually, let me back up a little bit. First question is, do I have to treat this? A lot of people will come in and say, I have pulsatile tinnitus. My uncle Fred dropped dead of a cerebral aneurysm, from a stroke last year, and I'm terrified that my pulsatile tinnitus. Once you come up with a diagnosis of sigmoid sinus wall abnormality without any evidence of intracranial hypertension or a high riding jugular bulb, something relatively benign, the answer is, of course, no, you don't have to treat this. This is for most patients, thank God, this is a quality of life condition. Not all patients, and that's part of our job too, is to separate the scary stuff from the not so scary stuff. But do I need to treat this? And some patients will be very surprised. Actually, no, you don't. If it doesn't bother you, it doesn't bother me. With of course some exceptions to that. So if they elect to treat it, you have to talk about what are the procedures, how is it done, how many of these have you done? I think that none of us really love that question when it's asked of us. But as a patient, if I'm wearing the patient hat, I want to know. I want to know if you've done 2. And there's a guy in town who's done 500, maybe I'll go to the guy who's done 500. I think that's okay. That's okay. When it's the patients, you can't worry about the doctor's ego coming into play there. What's been your success rate? And not only what is your success rate, is how do you define success? What do you mean success? Meaning absence of pulsatile tinnitus, decrease in pulsatile tinnitus, and over what time rate? Oh, great, my pulsatile tinnitus went away, but if it came back 6 months later in 100% of the patients, that's a problem. It doesn't matter if you have a 100% success rate if it's come back in 6 months. That's not a good long-term solution. And last, but probably most important, is what are the risks? What are the risks? What can go wrong? For many patients, this is a not life-threatening problem, and certainly not an immediately life-threatening problem. What are the risks? Do I want to trade a non-life-threatening problem for potentially life-threatening problem? Is this symptom bothersome enough for me that I need to think really strongly about weighing the benefits versus the risks? Fortunately, the risks are relatively low in almost all the treatments for almost all of the diagnoses that we have for pulsatile tinnitus. There are some exceptions to that. We are talking about major veins and arteries, oftentimes within the intracranial space. The risks can be quite significant. Rare, but there's a difference between rare and severe, and common and not very severe. So rule number 6, really, there are no rules. I started out by saying, ask good questions and blah, 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 but there are no rules. You're the patient. Ask the questions you want to ask. You have every right to know everything and all things going on about your condition. Don't be shy. There are people out there who can help you along. And although we are closing in on 100%, we're not at 100%. We are trying our best to get you where you want to be. And we are privileged to have that opportunity to partner with you on that road towards getting you whooshing-free existence if possible. So that's pretty much it from my end. And I want to again thank you my fellow panelists for allowing me to jump in.
Thank you. Thank you so much. If I can piggyback as a patient before we jump into Q&A on just a couple of things that you mentioned, Dr. Coelho, when I started experiencing pulsatile tinnitus or tinnitus, and by the way, there's no right or wrong way to say that. So I go back and forth all the time. I too saw many doctors with all the accolades on their walls that I thought would have the answers for me that just didn't, because they didn't have the training on the symptom. And so I want to encourage everyone that's watching who's a patient to be your best advocate. It is hard. It is hard to ask for the imaging, to get the CDs, to pay for the CDs, to get copies, multiple copies, and to deal with, personnel sometimes that aren't too happy that you're making all these requests. But as Dr. Coelho maintained, we are entitled to those. Those are our medical history, and they are actually really, really important as we circulate our films. So I'd encourage patients to do that. Also, to think about anything that might be significant or maybe not that happened at the same time as the onset of your pulsatile tinnitus. For me, it was just that. That's the only symptom I had. I could not think of anything else that was significant. There are those, though, that maybe went scuba diving the day before, which you wouldn't necessarily think could be related, and maybe it's not, but it could be. If you had your hair washed and you had your neck stretched back for a significant period of time, or you painted a ceiling, or you were in a car accident, all of those things, whereas they might not seem to be a direct relation to the pulsatile tinnitus we've seen in reports, could in fact be. So don't be afraid to mention those kinds of things. And finally, before we jump into Q&A, I just want to speak too on a personal level about discussing the psychological aspects of what you're experiencing with your doctors, and really encouraging you to do that. I did not do that. And I'm not really sure why. I think I've mentioned this in previous webinars. I suppose I had a very short period of time to speak with a doctor, and I felt like, okay, I'm not going to waste any time talking about how, I can't sleep well, or I can't focus as well, because I really just want to get to the heart of what's going on. But the impact it's having on you is really, really important. And I just want to encourage any patient watching who may be in the throes of all this and trying to find answers to not ignore that aspect, because that's super important. So now we're going to jump into our Q&A discussion for the next 45 minutes or so. We have this split up into various sort of chunks of time. So the first chunk of time is going to be devoted to COVID, which I know we collected questions before the webinar, many of which were related to COVID, both the sickness and also the vaccines. And whether or not there's any of the panelists have seen or have an impression that there's some relation to onset of pulsatile tinnitus, whether again from actually getting COVID or from any of the vaccines. And I would just like to throw that very general question to each of the panelists. Perhaps let's start with Dr. Sismanis, since you started the first session. Oh, and I believe you're still on mute.
Thank you, Emma. Yeah, it's a very interesting topic about COVID and tinnitus. There is no question that COVID has created a lot of anxiety and depression for many people. And we know that anxiety, depression lowers the threshold for realizing tinnitus or even pulsatile tinnitus. So without question, a number of people with pre-existing tinnitus, they have experienced increase of the loudness of the tinnitus. Now, overall, over these past several years, I've seen several patients that soon after they had COVID, they developed tinnitus in both ears. And in one of them, the hearing went down. But looking in a scientific way, looking at the literature, looking to see if there's any worth accepting study, I have not been able to find one. Although recently, there was a study from Harvard, actually, where they have a significant collection of temporal bones. These are the bones of people that they have died that they have donated to the medical school, and they have studied these specimens under the microscope. So we know that the virus, the COVID virus, does affect the cochlea, does affect the inner ear where you have the organ of hearing and balance. So does it happen? It perhaps happens, but it's not very common. Now, as far as specifically pulsatile tinnitus, I don't have any experience from patients.
Okay. Does any other panelist have any thoughts or opinions on the vaccines and any maybe increase in pulsatile tinnitus cases in the last couple of years?
Yeah, I don't think it's from at least from our practice, what we've seen, it has not been a huge problem, particularly considering the vast numbers of people who have been vaccinated. But I agree with Dr. Sismanis. And somebody, it's not always clear. I think all of us have seen patients who their pulsatile tinnitus started instantly, woke up one morning, boom, or whatever. And when you find the cause, it's clear that this was a cause that had to have been developing for a period of time. It's not something that could have happened instantly. Superior semicircular canal dehiscence, or sigmoid sinus diverticulum, a glomus tumor, they've all been developing over time. And presumably transverse sinus stenoses and other things like that, dural AVMs. Yeah, the pulsatile tinnitus starts instantly. So there was something else that contributed to putting them over a certain threshold there. And it could very well be that the inflammatory response and whatever changes the body has in response to that from a vaccine doing its job might change the blood flow in such a way that it makes something more noticeable. If that's the case, it's quite possible that over time it might abate again as the inflammatory response decreases. But it's not something we've seen a huge amount of, though it makes sense that it could be the case in certain people that it would make it might be the threshold event that makes it more noticeable.
To a patient that is perhaps, and I believe we discussed this at the last webinar, to a patient that's perhaps thinking about being vaccinated, hasn't yet been vaccinated, is concerned about either already having pulsatile tinnitus and the vaccine making it worse, or someone, perhaps who is just worried generally about getting pulsatile tinnitus with getting their first vaccine. Does anyone have any thoughts for?
I can comment on that. I mean, I'm by no means speaking for everybody up here, but I think you have to back up and look to see what is the natural incidence of the onset of pulsatile tinnitus, irrespective of its cause, on a yearly basis. And has that changed prior, during COVID or during the vaccines compared to prior? In my clinical experience, the answer to that is no. But as Dr. Eisenman mentioned, there's so many hundreds of millions of people getting vaccines, getting COVID, getting boosters, all these things that, temporally speaking, at some point, somebody is going to develop, it's a big world. Somebody is going to develop pulsatile tinnitus or tinnitus at the same time that they happen to get a vaccine, because millions of people are getting vaccines every single day. So somebody is going to get pulsatile tinnitus. Whether it's because of that or just happens to be at the same time is going to be impossible to parse out. As I mentioned, in our experience, we have not seen an uptick, which you would have expected with such high rates of COVID and such high rates of vaccination. Ultimately, it's a very personal decision. It shouldn't be political, but putting my doctor hat back on, I feel fairly comfortable saying that again, when you look at the risk benefit profile, that the benefits of being vaccinated, I think, are at least scientifically not up for much argument. there, and that although we don't understand the exact mechanism, I would say that the potential downsides that can come from being unvaccinated and suffering from COVID are probably greater than the upsides of not being vaccinated. Can I swear that that's the case? No, but we can give population-based recommendations. It's very hard to give individual-based recommendations.
I want to second another thing that Dr. Coelho had brought up, is that the importance of saying I don't know when we don't know. I think there's so much, and I agree with everyone here. I think I definitely support vaccination. I don't think that there is a strong association that can be proven between onset of pulsatile tinnitus and either the disease or the vaccine. And we have to think of the causes, like how can that happen? When we speak about these blood vessels and all these diseases, like what is the mechanism by which either the disease or the vaccine would cause pulsatile tinnitus? And those are a little bit hard to think of. And it's also something that I think is key, is that even though a lot of things are changing with COVID in terms of everything about it, the prevalence, the severity, where it is, how the vaccines are used, who's going to get them now. The one thing that I think is consistent is you've heard all these talks about this or that or the other cause. The infectious cause in general has so far not been mentioned. Like, what do we know about other viruses or other infections and their relationship to pulsatile tinnitus? And the relationship, as you can see, the infectious disease as a cause of that is really not very high. So by that extension, COVID is another kind of virus. We have many viruses running around. And so I think that's another way of thinking about it when people are making these decisions.
Okay. Does anyone else want to comment before we move on to another topic?
I just have one.
Oh.
I just have one comment that I've seen a lot of increase, like, the patients coming and saying, well, I have developed pulsatile tinnitus after, but I'm yet to find any cause on any imaging investigations on those patients. So no venous thrombosis, no venous stenosis, nothing really atypical than what we usually see in patients with pulsatile tinnitus without COVID. So that's why this coincidence between, because as mentioned before, the incidence of people getting COVID or getting vaccine is extremely high, and there's probably just coincidence, but there's nothing, at least we can detect, or we can see that it's typical or specific for COVID. So, and again, the benefits of getting the vaccine is outweigh by far the risk associated with it. And there's millions of patients or people getting the vaccine without any problem. So we cannot really find a causality between the COVID or the vaccine and pulsatile tinnitus.
Is there, I guess, before we move on, and by the way, there has also not been necessarily an uptick in membership to our very active Facebook page, which I know is not a scientific, thing at all, but it's notable just because our membership has been consistent as well, even from before COVID to now. Is there one last question about the vaccines? There has been some discussion about thrombosis associated with one or maybe more of the vaccines. If someone has a choice, I know some people don't, but if someone has a choice about which vaccine to get, is there one maybe they should consider last? Any thoughts about that, about the choice of vaccine?
If someone asked me that question, I would tell them to discuss it with their primary care physician.
Fair enough. Okay. All right. Anyone else?
I think it also gets to the question of the worldwide nature of our audience. Some parts of the world you can have, whichever color you want, flavor. Other parts you have, other vaccines, not necessarily as studied as well as others. So it's complicated.
Sure. Great. All right. Well, let's move on. I know we had several presentations that mentioned venous sinus stenosis. A number of our questions that were submitted related to venous sinus stenosis and the stenting procedure. So I wanted to pose some of those questions to the panel. one question is, what is the long-term safety and outcome of venous stenting and coiling? What data do we have sitting here today? Dr. Shapiro, actually, would you like to address this, since I know your institution just posted a journal paper on this topic?
We can talk a lot about it. I think it relates to Dr. Higgins's talk a lot, because we don't want to. We can spend forever talking about the association between it, sinus stenosis and intracranial hypertension. What's the chicken? What's the egg? What causes one? What's the other? But I think as we measure outcome, in my experience, I think it's important to separate which outcome we're measuring. And I think here we can make, there is some data. In terms of what happens in the long term with patients that have intracranial hypertension and papilloedema and so forth, what's the long-term outcome of stenting for that versus the long-term outcome of stenting for pulsatile tinnitus. Even if that comes as part of the package, the patient may have papilloedema and pulsatile tinnitus and so forth. So if we look, in my experience, and I think, as you can see here, with the people that are joining us, as you can see, it's so important that we have all these experts here. We may have different opinions about it or different algorithms in which we go about evaluating, but you can see there's a rationale and there's a wealth of experience that comes with that. So you just have to listen to what everybody has to say and how, what's been the outcome. In my experience, the outcome of stenting for alleviation of pulsatile tinnitus specifically, that is done for say venous hypertension or for venous sinus stenosis, can be abolished with, let's say, jugular compression of the neck. The outcome of that in the long term, and long term I mean like more than a few years, in my experience has been superb. I think the reduction in the amount of the sound, the volume of the sound, I think to me has been extremely consistent. Much more, I would say, than the long-term outcome in other measures of people that may have intracranial hypertension. So I think, as Dr. Higgins mentioned, a lot of people have this sort of subclinical, this not as you may not have papilloedema and so forth, but if somebody has pulsatile tinnitus alone and the pressure is a little bit high, or maybe higher this year than it was 2 years ago if you had measured it, I think for pulsatile tinnitus, the outcome I think is excellent.
If I can jump in and make a comment to Dr. Shapiro's, it's very interesting that there is evidence that even when the intracranial hypertension goes away, the stenosis of the sinus, in some cases, remains. So these probably are the best candidates that perhaps we have long-term satisfactory results, because they don't have the intracranial hypertension, or perhaps the intracranial pressure is all the way down.
Dr. Higgins, would you like to speak to stenting in general in your experience, and we had a question about long-term safety and outcome of venous stenting, and I know that we have not a lot of years of this procedure being done, but we have some. Would you like to speak to the procedure itself and its impact on patients and the medical field in your experience?
So my experience is exactly the same as Dr. Shapiro's. It's wonderfully successful for tinnitus. I think it's actually pretty good for papilloedema if you have full-blown idiopathic intracranial hypertension. But for headache in IIH or some of the other, if you've got a variant of IIH or pulsatile tinnitus, it's not so good at getting rid of of those other symptoms. So that's the first thing. The first case we did of venous sinus stenting was in 2000, and I saw her scan, it was about 5 years ago, but it seemed these stents seem to be very stable in the venous sinuses, and that's without any apart from immediately post-procedure without any long-term aspirin or antiplatelet treatment. So it really does seem to be a very, very stable, actually. The time when the stents do run into problems in the sinuses is sometimes if you put them on both sides, if there's not enough flow through one, you can get thrombosis in the non-dominant sinus, or if there is a stenosis in the jugular vein downstream, you can get thrombosis developing in the sinus. The other thing is that arachnoid granulations can gently percolate through the stent, sometimes quite quickly, and that can frustrate your attempts to treat intracranial venous hypertension and pulsatile tinnitus sometimes. So I think you have to be ready for that. But for treating pulsatile tinnitus, it's as long as that's the cause of it, I think it's very successful. We have more trouble trying to show a benefit in patients who have idiopathic intracranial hypertension form, but even there, I think it's pretty good. And what it tends to do in idiopathic intracranial hypertension is the stenting converts somebody who has a diagnosis of IH into someone who has a headache, because it usually takes the pressure down enough that the papilloedema resolves. But my own view is it doesn't get rid of IH. It just takes the edge of it. But a great interest of mine has been to try and understand why a procedure that often seems very successful when you first do it. I'm not talking about pulsatile tinnitus, I'm talking about IH, very successful in terms of symptom relief across the board, then seems to fail at 3 months. Why does that happen, and why do you not get a much better result than you might do? So there are lots of unanswered questions here, but there's no doubt in my mind that if you can make a diagnosis of pulsatile tinnitus caused by IIH or some subclinical IH, intracranial stenting is a very effective technique.
May I ask a question, Emma, Dr. Higgins?
Yeah.
Dr. Higgins, do you routinely do an LP and measurement of the CSF before stenting?
I do, actually, yes. I think it's, first of all, I routinely measure intracranial venous pressures and routinely measure CSF pressures. You're often surprised by either pressure measurement. Sometimes the CSF pressure is not as high as you're expecting, and of course this all in my view works into whether these patients have CSF leaks and how long they last had a leak, whether it was the day before. So for me, it gives a baseline and it tells me what I'm treating. So yes, I do.
That's very interesting. One comment, if I may make to your presentation. I strongly believe that pulsatile tinnitus is a main manifestation of IIH. I don't know if it's as equal as the papilloedema, but I think it's very, very important manifestation. And again, it's an old man's bias, probably opinion, that many of the patients that I see with pulsatile tinnitus, guess what? They don't have papilloedema. And they don't go to an eye doctor or even the headaches, they're not that bad. I cannot prove this to you. We're working on it, but this is my impression. Pulsatile tinnitus in an obese female patient is almost 100% IIH syndrome. I have not seen a single lady who is obese and has pulsatile tinnitus that she does not have intracranial hypertension.
I think that's probably pretty close to my experience as well. But at the same time, I think what is very difficult is the concept of IIH without papilloedema is something that certainly neurology over here in England have found very difficult to get to grips with. And the idea that you might have something similar if you don't quite make the cut also is very difficult. And in fact, the cut itself at 25 centimeters of water is partly designed, in my view, to keep patients out of the hands of surgeons or someone who might want to do something about it. And papilloedema is such a clear thing, and it's something that nobody can avoid. It produces such fear amongst the clinicians, but it's the other symptoms, of which pulsatile tinnitus is one, of patients who have IIH that I think are often very disabling. And as I alluded to in my in my presentation, I think many of these patients with a variant of IIH do have a lot of these other symptoms if you ask them, and they're very distressing.
That actually goes to my next question about this is for a patient that just presents with pulsatile tinnitus, which we know has varying levels of impact on patients. What about the decision whether or not to have a stent put in? How do those conversations generate with the patient? Because we have a lot of people in our community naturally with a diagnosis of transverse sinus stenosis, many of whom have been provided the choice, sometimes the very difficult choice, whether or not to endure the stent procedure. Some of whom have noted the lack of long history of studies on stents and what happens to a stent after 40 years. Can anyone speak to, I guess, the conversations you may have with the patient to help them decide whether or not a stent is the right decision for them?
I can answer part of this question at least, but first I'll answer your first question about some numbers of the safety. There are some probably 5 to 6 years study that looked to the patency and after 5 years of placement of the stent. That was done in patients with intracranial hypertension, not necessarily just for pulsatile tinnitus. And they showed in 5 years up to 90 or more than 90% that are patent after 5 years. And the main risk of recurrence or restenosis or the need of additional treatment was actually increase of the body, the weight of the patient. So in 5 years, that's very, very good. And then there are meta-analysis, like that means a combination of many studies that look how safe or how effective is stenting in treating the symptoms of IIH in general, the headache, the visual problems, or papilloedema, and the success rate was approximately between 85 and 92 or 93%. So it's very success, and it's not even for isolated pulsatile tinnitus. Pulsatile tinnitus, as Dr. Shapiro mentioned, is one of the most highest success rate with treating pulsatile tinnitus with stenting. So it's relatively, now with the midterm, I can say 5 years is approximately midterm, it's been proven to be very effective, very safe, and most importantly, does not recur. So 90% success rate in 5 years is pretty high. Now, what I discuss usually with my patient when I consider stenting, that we know very well that the stent, with time, we call that endothelialization. That means part of the coverage of the vessel will extend to the stent, and the stent will be embedded with the body and will be part of the blood vessel. So, and that's why some of the patients, we really stop blood thinners after 1 or 2 years because it's not needed anymore. The stent is kind of part of the vessel. And usually those, especially the vessels, blood vessels or the vein inside the brain, they don't change in caliber in adulthood. So they don't grow or increase. So we don't worry about the change or migration of the stent or with the available data that we have, stenting has been proven to be safe and effective. And for long term, we don't have like 10 or 15 or 20 years of big studies for more than 10 years. But what's available now, it's very promising.
Great. Anyone else before we move on to other topics? Okay.
No, I guess I think we should. I also want to echo this very quickly, that as Daniel mentioned, for many people with isolated pulsatile tinnitus because of venous sinus stenosis, it's not that the disease is dangerous. It's the question of to what extent it interferes with one's life and what risks they're willing to take to get rid of it. And that's the two. So we know, I think it's generally very effective. The question of risk is a key question, because the risk really depends on an individual, depends on the practitioner, certainly what they do, how much, and it depends on the person's perception of risk. For somebody, 1% might be a lot of risk for somebody and very little for somebody else. But the more we do this, and I think the question of like long-term, the more important question to me is like, how do we understand the risk of this procedure amongst the different practitioners and settings? We don't really know enough about it, I think. I think in people that do this a lot, the risk is low, but there are publications on bad things that happen. And it's important for whoever is getting this to understand that this is not risk-free, and the risk has to do with your head. So that's my comment.
I think that we all agree that before standing or any other type of invasive procedure, conservative means of treatment have been tried. For example, just 5% reduction of the weight can put the syndrome, the NII syndrome, under control and decrease the tinnitus. Of course, we have tried this before standing, and also acetazolamide, which also is the treatment of recommended by neurologists for II syndrome.
Okay. We're going to switch gears for the last 15 minutes or so. We have a bunch of random, very good questions that I wanted to pose to the panel. So I'll just dive right in. So of course, we know that pulsatile tinnitus can be one-sided on the left or the right, or bilateral. And the question is, are there diagnoses that are more common or specific to those of us who suffer from one-sided pulsatile tinnitus, right-sided, left-sided, or bilateral? Dr. Eisenman, do you want to comment on this question?
I will make one preliminary comment, which is the otologists amongst us are aware of something called a Stenger phenomenon, which is that if you're presented with one sound to each ear that is exactly the same, but one of them much louder than the other, your brain will only perceive the sound on the louder side. This is something that audiologists use routinely in their clinical practice to try to detect what might be called a functional hearing loss, or someone who maybe is for some other gain trying to claim a hearing loss. The implication of that is that if you have something that's producing pulsatile tinnitus in both ears, but one of them is much louder than the other, you will only hear it on the one side, even though it's present on the other side. And so we've seen many patients who we treat a pulsatile tinnitus on one side, and afterwards they say, that's amazing, it's gone, but now I hear it on the other side. And there are a couple of reasons why that could be the case. It could be if your treatment involved some type of, if you decrease the venous outflow, let's say through the transverse sinus on one side, you might have increased it on the other side, and that makes them hear it then there. But even if you didn't do that, even if you caused no outflow stenosis, just by abolishing the sound on one side, they may now hear it on the other side. It was there all along, but they just weren't hearing it. So first you have to exclude that whole category of people, that it's actually there on both sides, but you're not hearing it on both sides. Transverse sinus stenosis, sigmoid sinus wall anomalies, they can certainly be bilateral. IIH is most commonly associated with some degree of bilateral transverse sinus stenosis. So it can be a more uniform all over sound. Dural vascular lesions, glomus tumors, any kind of tumor causing it, will more likely be a unilateral sound. Sigmoid sinus diverticulum dehiscence are about twice as common on the right side as on the left side, but they can be on either side. So yeah, there are certain things that will be more commonly one side or the other or both, but you have to be aware of that first possibility that maybe it's in practice on both, in reality on both sides, but in practice only being heard on one side until maybe after you treat the one side.
Interesting. I did want to mention, and I should have done this earlier, that our community petitioned years ago for diagnosis codes that were not the tinnitus codes, that were distinct from the tinnitus codes, and those in many parts of the world have been have started to be recognized and used, and insurance companies gladly are recognizing the differences in those codes in getting diagnostic tests approved, which is great. And those are split up into the 4 right ear, right side, left side, bilateral, and unspecified. Thank you. So to those of you that may not be familiar with those codes, those are all listed on the wooshers.com website. Make sure that your doctors are familiar with those codes, because those can make a big difference, especially as you're getting imaging approved by your insurance companies, because the tinnitus codes will just signify first the wrong symptom that you're experiencing, and also since there's no known cure for tinnitus, the insurance companies may be reluctant to pay for or help pay for your imaging.
Right. That used to happen all the time, that a request for an imaging study would be denied because it was a diagnosis of tinnitus. And so, Emma, we can't give you enough applause and kudos for spearheading the effort to get that accomplished. Another, I don't know if it was intended or unintended, benefit of having the codes is that it's really facilitating research in the field, because if you want to look back at your previous 300 or 400 patients that you had with pulsatile tinnitus, you can now do that with a simple electronic record search using those codes, whereas in the past it would have been impossible to do. So it's a tremendous accomplishment.
Thank you. Yes, very, very happy about those. A related question about the pitch of the pulsatile tinnitus, high or low. I wonder if any of the panelists can speak to maybe causes that are more likely to be a loud sort of sonogram-like sound versus a higher pitch sound that some describe like a bunch of birds squawking.
Sure. I can speak on that.
Great.
Yeah, so I'm really glad somebody asked that question, because just as we had mentioned before, that pulsatile tinnitus itself is not a diagnosis. There actually are different types of pulse synchronous tinnitus. And you have to ask the patient, well, when you say pulsatile tinnitus and it goes with your heartbeat, what are we talking about? The name of your organization is Whooshers, but some people with pulsatile tinnitus don't call it whoosh. No, they'll say it's not whooshing. It doesn't sound like an ultrasound, although the vast majority will say that. Some people say, no, it's more like a beep or a ring, or kind of a very high pitched, very, it doesn't sound like an ultrasound at all. And those are most likely reflective of the fact that we're talking about different pathophysiologies contributing to the pulsatile tinnitus. A whoosh is going to be more of a vascular issue. I do have a handful of patients, more than a handful of patients, who have high frequency sensory neurohearing loss, and that tends to be arterial. I think it's more categorized as almost more related to what we refer to as primary tinnitus. It's just primary tinnitus that is very high pitched and ringing that happens to just be in a pulsatile nature. And that's probably an intracochlear problem that's happening, or a problem with inhibition that's happening inside the cochlea. There's not been a lot of research on this, but I personally consider that very different, and the workup for that is very different. These are generally people who have high frequency sensory neurohearing loss. I mean, when you think about it, it's kind of amazing that we all don't have pulsatile tinnitus in all of our ears all the time, right? Our cochlea is right next to our carotid and our jugular bulb. Not to mention that our cochlea has blood vessels within it. Why are we not hearing that? How can there be blood vessels inside the cochlea that we're not hearing? And that's because through mechanisms that are frankly poorly understood, there's inhibition that's happened. So inhibition is something that means that your brain is pushing down the tinnitus. It's blocking out the tinnitus. And for primary idiopathic tinnitus, and for this weird subvariant of pulsatile primary idiopathic pulsatile, subjective tinnitus, that's probably a loss of the inhibition. Why it happens in most people to be just a continuous ring or high-pitched sound like a radiator or something like that, versus why other people get it pulsatile, I don't know. I'm not sure anybody knows, but it's very important to alert your physician about the sound. Don't let the physician just railroad you into saying, "Oh, I know what you're talking about. It's pulsatile tinnitus." It's like a, he or she may be thinking that what you mean is an ultrasound. But for some people, it is definitely not that. For some people, it can even be a venous hum. So it may not even be on, off, on, off. It would be, for some people, it could be just become all the time, with slight variations that do. So it's important to kind of get that across. I'd be curious to hear what some of the other people's opinions are on that.
I fully agree with what you said, Dan. Also, we see this type of tinnitus in pulsatile tinnitus in patients with migraine, high-pitched bilateral. And by the way, most of these patients, they have hearing loss already done, mention it in the high frequencies. So migraine and high-frequency sensory neural hearing loss, you can have bilateral high-pitched pulsatile tinnitus.
We have, for those that may not be familiar, doctors as well as patients, we have on the wooshers.com site a sounds page, which happens to be our most popular page historically, where we have links to audio files of whooshing sounds. And you can hear there, you just click and play. I hope all the links work. If they don't, let me know, or let someone know, just send an email to the site. But it's great, especially if you have subjective pulsatile tinnitus, meaning only you are able to hear it, to find an audio file that sounds like yours so that you can play it for your doctor. I found it very helpful before my objective pulsatile tinnitus was determined that I could play the same for my friends and family and say, this is what I hear every other second. Imagine that, and after about 30 seconds of listening, I can tell you that people will have sympathy for you. And maybe in all seriousness, you might get more attention in your doctor's office, especially if they're unfamiliar with pulsatile tinnitus. So please do visit the sounds page. And we have all sorts of variations of sound submitted. By the way, if you have objective pulsatile tinnitus and you can record your sound, we have a number of real pulsatile tinnitus sounds submitted by various people from all over the world there. So do check that out.
I would just say quickly, we know from audiology studies that the pulsatile tinnitus from hearing tests, when you do a hearing test on someone with pulsatile tinnitus, the sound is going to affect their hearing, because the extent that they're hearing that, they're not hearing as well. And so we know from looking at hearing tests that have improved after treatment of sigmoid sinus diverticulum dehiscence or transverse sinus stenosis, that's usually a relatively low frequency sound in the range of 250 to 500 hertz. And we know that because the person's hearing improves at those frequencies after the treatment of the problem. So some of these the most common venous causes are generally going to be a relatively low frequency sound.
An easy thing to do is ask the audiologist to repeat the audiogram while the patient is holding his neck and pressing and alleviating the tinnitus. You'll see it's the only sensory neural hearing loss that I have seen that it's treatable right on the spot just by this single test. And yes, I hesitate, but I will do it. If I may ask a question, my distinguished interventional colleagues, about one thing that I would like to know. In patients with arteriovenous type of pulsatile tinnitus, when you do this test, the neck pressure test, does it go away or not? Does it affect the loudness of the tinnitus?
Usually doesn't affect it so much.
I fully agree with it.
Sometimes it makes it worse or better, but
exactly.
it's not this test. And just like as we were talking about, for venous diseases, in our experience, we calculate numbers. This is as good as an MRI. If you do this and the sound stops, 90% of the time, it's going to be venous sinus stenosis. Positive, negative, predictably, all these statistical things. This is free. You could do it anywhere, and it's a great, like the person that has pulsatile tinnitus should try this very gentle compression. We tell everybody, don't press too hard, don't squish your carotid artery, just push a little bit. And if it changes a lot, that's very important.
Maksim, I've seen only 2 cases that pressure, not on the neck, just behind the mastoid, but a lot of pressure. Cases of AVFs. But guess what? That was the feeding vessels, of the AVF. And one of them was actually an otolaryngologist that he had his associate in the group ligate before doing any imaging study. Ligate the postauricular artery. Guess what happened?
Probably get better and then get worse again.
Can anyone speak to, and you know what, we're at the top of the hour, and if it's okay with our panelists, we'll hang on for a few more minutes. If you have to leave, we understand, but maybe 10 more minutes of questions if you're able. We had a lot of questions about hearing loss, actually, and about hyperacusis. I wonder if someone can speak to the relationship between hearing loss and pulsatile tinnitus, and also hyperacusis.
I can touch on it in generalities. There are some conditions that come to mind when you see that certain constellation of hyperacusis, tinnitus, sound sensitivity, even hearing loss. The first that comes to mind as an otologist and a surgeon is superior semicircular canal dehiscence, which is a malformation that can be acquired over the course of years and decades, where the inner ear becomes basically in continuity with the dura, the bone of the skull base thins out. There are other inner ear, what we call third window syndromes, where it's not only superior canal dehiscence, but other abnormalities or dehiscences. Dr. Eisenman mentioned some of them earlier that can lead to that constellation. The other is migraine sensitivity to sound, phonophobia, phonodynia, which means pain or discomfort from sound, and pulsatile tinnitus. From a history point of view, it's probably easier to differentiate the two, in that the migraine-related tinnitus tends to be, the migraine-related pulsatile tinnitus tends to be more high frequency. Those people frequently have high frequency sensory neural hearing loss on their audiogram, and it's more of a high pitch. When I say high frequency, I mean high pitch. Whereas the superior canal dehiscence don't necessarily have hearing loss. If anything, they have, because of the mechanics of the inner ear, they actually do have sensitive, more sensitive. It's an alteration in the perception of sound, and they'll have usually what we call a mixed or a super threshold hearing loss as well. And their tinnitus tends to be more low threshold. But both of those will be associated with hyperacusis. Hyperacusis in itself is for the little amount that we know about pulsatile tinnitus, we know significantly less about hyperacusis. Hyperacusis, I mean, I could talk about it for a while, but it's not a great term for it. Hyperacusis makes it sound like that you have some sort of Superman type hearing, where you don't. Hyperacusis almost usually should be referred to as sonodynia, sound discomfort or aversion to sound. But CAT scan would be the gold standard. These are things that are relatively any kind of inner ear abnormality can be readily diagnosed, usually by an otologic surgeon or a good neuroradiologist.
Okay. Anyone else would like to comment on hearing loss and hyperacusis? I suppose last question about contrast. There's been some discussion in the last 5 years, especially of imagery to consider with or without contrast. Is contrast necessary? Some patients have referred to some concerns about not just allergies, but I think other complications with contrast. Can anyone comment on contrast generally and some of the concerns, maybe considerations for a patient? Again, provided the choice whether to have a test with or without contrast.
Yeah, I can answer this question. So first, contrast, like the contrast we use for MRI is totally different than the contrast we use for CAT scan. So those are totally different things. So now, obviously, there are a risk associated, but this risk is extremely minimal, especially with the newer agents, either for CAT scan or the MRI. We definitely have much better agents or contrast agents than 5 or 10 years ago. So we know that very, very well from the chemical composition of the newer contrast, with less effect, it does less affect the kidneys, it's less allergic reaction. So even now, there are some contrasts that we can use for patients with kidney problems. So that's very important. Now we definitely, especially if we want to do more comprehensive evaluation of for vascular cause of Pulsatile tinnitus, contrast is definitely much better. So imaging studies with contrast will allow us to see the vessels, and especially in the CAT scan. And the MRI, we can do some studies, especially looking to the arteries of the brain without the need of contrast, like we can get MRI and MRA. But contrast is still needed, especially if we are interested to look for a higher resolution or better quality images of the venous system. So overall, I personally prefer, and I think there are already my colleagues will agree with me, that a contrast-enhanced study, especially if the patient is going, so probably it's better if you go one time, get the full evaluation with contrast, especially given the very, very safe contrast that are present nowadays. So from interventional or from surgical standpoint, contrast is needed for full evaluation and comprehensive evaluation. Obviously, there are some very, very few instances where there are documented allergy to contrast, and there also a way to prepare the patient, to prep the patient to get contrast if they have allergies. But overall, the safety rates are very, very high, and the benefit of it outweigh by far the very small risk associated with it.
Anyone else like to comment on contrast generally? Okay.
I agree. I think that I agree with everything. I think the question really comes up with a patient. What happens when the patient just doesn't feel comfortable? For whatever reason. It doesn't have to be. We can debate for why, but it's okay. I just don't want to have it. I think if you're coming to a specialist in pulsatile tinnitus, I think you can begin the diagnostic journey without contrast. Yes, it's definitely not as good. Is the point, will it come to contrast if something is found? Probably. They'll have to make that decision. In some cases, you probably end up not using it and say, it's safe enough that we can wait or something like this. But for the vast majority of people, definitely with contrast is better.
Okay. Sorry, one last question quickly. And I think this might be a good way to round up the session today, which I think has been just great. If a patient or when a patient sees a medical professional and before any imaging is done is told that they have to live with pulsatile tinnitus, what should the patient do? Before any imaging is ordered, a declaration, clearly they must be treating, the medical professional must be treating the pulsatile tinnitus as regular tinnitus, and not directing the patient in the direction of a proper workup. What though can the patient do from that moment?
I think Dr. Coelho addressed that in his introductory talk, which is they probably should see another physician. Having said that, I would add one caveat that is very often the case, and I think Dr. Coelho alluded to it as well, that what the doctor says is not exactly what the patient hears. And I can tell you with 100% certainty that the words, "you just have to live with it," have never once come out of my mouth talking to any patient with tinnitus. But yet I've had patients of mine with tinnitus go down to the audiologist afterwards and say, "Oh, Dr. Eisenman said I just need to live with it." Make sure you understood exactly what the doctor said. And, but more briefly, what Dr. Coelho said is certainly correct, that if you don't feel your complaint is getting the proper attention, you need to see another physician.
I'm sure you'll have seen patients who've actually had to travel through several physicians before they get to somebody who can look after them properly.
And this is a challenge in various parts of the world with healthcare and the way we as patients are able to get care and seek those that we know may know better. Sometimes it takes months or years, unfortunately, for some of us to see each of you. And I just wanted to, again, thank each of you for your time today. Speaking of validation, which many of you mentioned in your presentations, whether it's a doctor hearing the pulsatile tinnitus by putting a stethoscope up to the neck or head, and the patient finally realizing, I'm not crazy, is such a relief. And I think having panels like you, 6 of you, devoting your time to helping us all understand everything a little bit better is also validation that there are doctors that know and understand and care and help and are available for all of us. So thank you all so much for your time today. I think this was great. We covered a lot of questions, not all of them. We'll do this again, and I really appreciate your time and glad so many people could attend. So thank you very much.
Thanks for having me.
Thanks very much.
Thank you very much, Emma. Thank you.
Thank you, Emma, for everything.
Thank you. Have a wonderful day.
Bye-bye.
Thanks. Okay.
Have a great day.
Bye-bye.
Bye-bye.
Bye.